Okay, welcome back everyone. This is going to be the last session of the Gastric Cancer Summit, but in many ways this may be the most important session, advancing early detection, which is the overarching theme of the summit. So we have 4 excellent speakers and panelists today. The first speaker is Professor Elena Stoffel from the University of Michigan. She is the director of the Cancer Genetics Clinic at the University of Michigan. She trained at Brigham and Women's Hospital and earned an MPH at Harvard School of Public Health. Her clinical and research interests focus on diagnosis and management of individuals with a genetic predisposition to cancer and developing strategies to improve early cancer detection and prevention. Dr. Stoffel.
Thank you very much to all of the organizers, and thank you for that kind introduction. I have no disclosures relevant to this presentation. I always like to start with a case, and this was a 59-year-old woman who presented for genetic evaluation, prompted by her personal and family history of breast cancer. In looking at her family history, she herself had been diagnosed with ductal carcinoma in situ at age 40, and her sister had recently been diagnosed with her second metachronous breast cancer. In addition, there was a first cousin with breast cancer as well. So a diagnostic test was ordered, and she actually, by her, not her oncologist, but actually her gynecologist had ordered a multigene panel test, germline sequencing of 59 genes, which uncovered a pathogenic germline variant in CDH1. So CDH1, just to review, is mutation it encodes for E-cadherin, which is a cell-cell adhesion molecule. It's considered a tumor suppressor gene and has been associated in the literature with lifetime risks of gastric cancer approaching 80% and lifetime risks of breast cancer, primarily lobular breast cancer, of 40%. In data that has come largely from multiple studies from different places in the world, including the Maori populations in New Zealand, as well as populations in Portugal, have demonstrated that most of these cases of CDH1-associated gastric cancer present as linitis plastica at advanced stages. And in talking with Sue Perry, a gastroenterologist who has managed dozens of Maori families in New Zealand, there are multiple cases in which individuals undergoing careful surveillance have developed metastatic gastric cancer, even being watched as carefully as possible. As a result of this, international consensus guidelines have recommended that individuals with CDH1 germline mutations undergo total prophylactic gastrectomy. So in the context of this 59-year-old woman who has received a diagnosis of CDH1 germline mutation, I thought it would be important to be able to look at the diverse clinical phenotypes that we're seeing associated with CDH1 germline pathogenic variants. And this is a great opportunity to identify what additional information do we need to be able to improve the care of these affected patients and their at-risk family members. So there have been a number of different papers and position statements written, and this one by Bryson Katona and Susan Domchek actually was entitled CDH1 on Multigene Panels, Look Before You Leap. And basically what they did was they tried to caution individuals ordering germline genetic testing that if CDH1 is on that panel, you better be prepared for how you're going to manage the patient once you have a pathogenic germline mutation identified. So why is this all of a sudden a problem? Well, we didn't do an awful lot of testing for CDH1 germline mutations before multigene panels came along. And the reason for that was that international guidelines for CDH1 germline testing were really pretty narrow, and were really quite narrow and gave us a really prescribed list of patients for whom we should consider it. Primarily, it was individuals with diffuse gastric cancer who were diagnosed at young ages, families in which there were two or more gastric cancers, at least one of which was a diffuse gastric cancer, and individuals who had a diffuse gastric cancer and or a close family member with lobular breast cancer, with one of these diagnosed at a young age. But what new data are showing us is that up to 65% of families with CDH1 mutations don't meet these criteria. So what we were finding in the past was the tip of the iceberg. So this family here basically shows you what we would think a typical CDH1 family would look like. An individual with breast cancer and gastric cancer diagnosed in the 40s and 60s, another individual with gastric cancer, another breast and gastric cancer, and then another gastric cancer up here. So that would bring to mind a CDH1 germline mutation. But what we're seeing in clinical practice is a lot of families that look like this. So a person who underwent a multigene panel test, just like our patient, for a breast cancer history, that when you look way up in subsequent generations, you actually don't see any gastric cancer as far back as you can look. So what does this mean for those risks of gastric cancer that we were talking about that come from historical populations that were ascertained on the basis of family history of gastric cancer? Well, this study that was done by Rosa Cicola and Xavier Lohr out of Yale actually used data from commercial genetic testing laboratories and tried to use this to estimate what the lifetime risk of diffuse gastric cancer would be among individuals who were not necessarily ascertained on the basis of gastric cancer history in their family. And what their analysis basically showed us, based on pedigree data from really only 36 families, excuse me, was that the estimated lifetime risk for gastric cancer was what they found was much lower than what the historical data suggest. And basically a lifetime risk for gastric cancer for men of about 37%, for women 25%. But interestingly, the breast cancer risk was the same as reported in previous studies. Now this paper has generated a lot of controversy, and I've had a lot of conversations with the authors because your analysis is only as good as your data are. And I think that one of the issues that we see still in the United States right now is that the vast majority of individuals who undergo germline genetic testing are undergoing germline genetic testing prompted by their personal or family history of breast cancer. So I don't think these data show us the entire picture. So the uncertainty here about the magnitude of gastric cancer risk is really impacting the care of these patients and families. The fact that you're seeing families where maybe nobody has a diagnosis of breast cancer, and you're explaining to them that their gene mutation means that their likelihood of dying of gastric cancer is incredibly high enough that you would recommend a prophylactic surgery, is really earth-shattering. And I think that as you'll hear from Dr. Davis shortly after, our ability to detect these cancers is really impaired because, as you can see in this picture, this stomach looks entirely normal. And this is a picture of an individual with an early stage diffuse gastric cancer. So the fact that that there is uncertainty about the magnitude of risk for gastric cancer, the fact that we don't have an effective screening test, and the fact that the alternative of prophylactic gastrectomy is not without risk really makes it incredibly difficult for these families to come to terms with the best management strategy. So what do we do for these families in clinical practice right now? Well, the international consensus guidelines suggest that even though total prophylactic gastrectomy is the optimal management, that individuals should still undergo at least a preoperative upper endoscopy procedure with biopsies performed according to Cambridge protocol. So this consists of a high-definition white light upper endoscopic exam with careful inspection of at least 30 minutes, trying to remove all of the mucus, and taking multiple biopsies, at least 30 biopsies, some initially targeting anything that catches your eye, any white spots, and then with random biopsies of the cardia, fundus, body, and antrum. And importantly, these biopsies actually require expert pathologist review because what you're literally looking for is signet ring cells, which can be like needles in a haystack. So can we detect diffuse gastric cancers at an early stage? This picture actually shows you those infamous white spots that actually looks really subtle. But sometimes on biopsies, you actually find that needle in a haystack, and you actually find these signet rings, these clusters of signet ring cells, which are the in situ signet ring adenocarcinoma. So a study, I believe that this was a group out of Mass General. They actually tried to estimate how many biopsies you would have to take to be able to detect a gastric cancer, one neoplastic focus with a detection rate of 50%. So the number of biopsies needed ranged from 50 to 5,000 biopsies. So we are basically trying to do our best to find something that helps make the decision easier about surgery. So this diagram actually demonstrates our published data from University of Michigan from endoscopic evaluation of 20 probands with CDH1 germline mutations. We performed upper endoscopies according to the Cambridge Protocol on all of them. And on the initial endoscopy, 8 out of the 20 had signet ring cell adenocarcinomas identified. 2 of these individuals did not go to gastrectomy, but the rest did, and the gastrectomy specimens confirmed the signet ring cell adenocarcinoma. Interestingly, of the folks who had histologically normal stomachs, 2 opted to undergo gastrectomy and were actually found to have signet ring cells. So their endoscopic biopsies were falsely negative. What's the difference between the people who had signet ring cells identified on their evaluation versus those that didn't? Interestingly, the age ranges were the same in each group. The individuals with signet ring cell carcinomas identified ranged from 23 to 70 years of age. Only 40% of those individuals had actually had gastric cancer diagnosed in a first-degree relative, and fully a quarter of them didn't have any diagnoses of gastric cancer in their first or second-degree relatives. So this diagram actually was our attempt to try to illustrate how family history impacts what you find on your endoscopic or gastrectomy specimens. So on this axis, this is the number of relatives, the number of first and second-degree relatives with gastric cancer, and this is the number of first and second-degree relatives with breast cancer. What I'd like to call your attention to is in these individuals who have no first or second-degree relatives with gastric cancer, the red figures represent people with a diagnosis of gastric cancer. So you see that even in the absence of any family history of gastric cancer at all in first or second-degree relatives, we're still seeing signet ring cells. So since we published this paper a year ago, our cohort has now doubled in size. As more and more people are having multigene panel testing, we're finding more and more mutation carriers. And interestingly, the proportions have stayed roughly the same, with about 52% of our mutation carriers having positive either biopsies or gastrectomy specimens with cancer. Fortunately, all but one of these have been early stage cancers. The one that was not an early stage was actually someone who had a preoperative endoscopy that showed in situ signet ring cells, but didn't detect a 3-centimeter tumor that was in the cardia. So let's go back to our patient. So our 59-year-old patient has a CDH1 mutation. And everybody says, wow, how did this happen? Well, we did some digging, and she did some digging and talked to family members. And it turns out that one of her sister's breast cancers, one was a ductal carcinoma, but the other one was a lobular breast cancer. And then she talked to her family members about her diagnosis of CDH1 and found out that a cousin who she had lost touch with had actually died of gastric cancer at age 42. So what was really important here was that prompted her to undergo an upper endoscopy, which interestingly showed no signet ring cells on her biopsies, but she ultimately underwent a gastrectomy, which did confirm that she had in situ signet ring cell adenocarcinoma. Subsequently, she got in touch with her cousin's relatives, and her cousin's 4 children all underwent germline genetic testing. They all had carried the CDH1 mutation, and 3 of the 4 of them had signet ring cells. endoscopies, and they're planning to undergo gastrectomy. Interestingly, her cousin's brother, who is in his 60s, who tested positive, had a negative upper endoscopy, and he's decided that he's going to defer gastrectomy for now. So the challenges in management of these families are, as we talked about, the variability in the penetrance and expressivity. But the other really worrisome or disturbing piece of information here is that the natural history of these in situ signet ring cells is not known. Does everyone require a prophylactic gastrectomy? And this kind of calls to mind what we used to, the prostate cancer story. That basically, if men live into their 90s, virtually all of them will have prostate cancer diagnosed, but very few of these prostate cancers would have been lethal. I think that the story of signet ring cell adenocarcinoma and CDH1 carriers may be similar to that. We know that virtually all gastrectomy specimens will have in situ signet ring cells, but how many of these would have actually gone on to become metastatic gastric cancer? And since we don't know what the natural history of this is, it's hard to decide when would be the best time for a gastrectomy, which has the potential for being life-changing for many patients. I'm sorry that Chin He is not here because this is actually his Markov model, looking at trying to model the optimal timing for gastrectomy for CDH1 mutation carriers. And taking into account a number of parameters, including the risk of developing lethal gastric cancers and quality of life, Chin and his colleagues determined that the optimal age for gastrectomy for men would be around 39, for women would be around age 30. And the current recommendations are to consider gastrectomy anytime after age 20. What was important about his model was that he found that gastrectomy reduced cancer mortality and increased life expectancy regardless of the age when it was performed. So going back to our family here, all of these siblings here have decided to undergo prophylactic gastrectomy. Their uncle has decided to defer for now. And I think the fact that there were signet ring cells identified on their endoscopic exams may have helped make that decision easier for them. But what about a different patient? What about this 26-year-old who actually tested positive for the CDH1 germline mutation that was identified in her mother when her mother was tested based on a history of breast cancer? And in this family, there is no gastric cancer at all. But she has 3 relatives with premenopausal breast cancer, and her upper endoscopy shows no signet ring cells. So for these patients where you're trying to manage the risk for developing breast cancer, the risk for developing lethal gastric cancer, the fact that we don't have a reliable screening test really makes it challenging to both counsel these patients and for the patients themselves to make decisions. So in summary, hereditary diffuse gastric cancer is much more common than we thought. The fact that we're identifying new cases on a weekly basis is really making this an incredibly important condition to study. The absence of family history should not provide reassurance about the risk for gastric cancer. And I think that what we've shown is that we see these signet ring cells in these patients, and these signet ring cells are you never find these in the average patient. So they're definitely abnormal. Prophylactic gastrectomy remains the standard of care for reducing gastric cancer morbidity in hereditary diffuse gastric cancer, but it's certainly a big decision to make and has lifetime repercussions. So I think that for future directions, what we need to look at is we need to actually find out what factors influence the risk for diffuse gastric cancer. Does it depend on the particular CDH1 mutation you have? Are there other genetic modifiers? Are there environmental modifiers? And are there any of these factors that we might be able to modify through health behaviors or diet? What makes signet ring cells progress from diffuse gastric cancer and metastasize? These little clusters of in situ signet ring cells, is there something else that makes them develop into linitis plastica and peritoneal carcinomatosis? And finally, how can we improve early detection? And my answer to that, I think, is going to be through improving screening and reducing false negatives. And on that, I'm going to pass it off to Dr. Jeremy Davis, who's going to tell us a little bit more about what we can do to find these and find these more effectively. So I wanted to say thank you to our team at University of Michigan, our gastroenterologists, our cancer genetics team, and especially our GI pathologists, Henry Appelman and Karen Choi, who really do the painstaking work of looking at each one of these biopsies at multiple levels, and also our surgeons, Mike Mulholland and Sandra Wong, who's now at Dartmouth. Thank you very much.